Familial Exudative Vitreoretinopathy related retinal detachment, surgical management. The class will be moderated by Dr. Pradeep Sir. We've already covered this, that FEVR is a heritable vitreoretinopathy with anomalous retinal vascular development, works on the WNT beta-catenin signaling pathway. Autosomal dominant is the most common form of genetic inheritance, followed by autosomal recessive and X-linked recessive. So FEVR basically has peripheral avascular retina, which can go into neovascularization, exudation, and retinal detachment. Retinal detachment is a complication leading to visual disruption that occurs in 21% to 64% of eyes with FEVR. And rhegmatogenous related retinal detachment is more common than tractional or exudative. Talking about the tractional component, so fibrovascular proliferation can occur in FEVR up to 18 years of age. In less than 3 years of age, the fibrovascular proliferation is rich in vascularization, occurs over a wide area and grows rapidly. Once in older patients, it's more rich in collagen, poor in the vascular components, and has a restricted area of involvement and progresses slowly. So this means that younger patients have more aggressive form of FEVR. Exudative component, so there can be varied amount of subretinal exudation. If the subretinal exudation is severe, then it can be confused with Coats disease and can lead to accumulation of fluid causing retinal detachment. There was a case report which showed that persistent SRF was minimally responsive to other anti-VEGF agents but responded to faricimab. So there could be a role of angiopoietin 2 receptors in this exudative component. Rhegmatogenous component, it is basically caused by global enlargement. So because of myopia, lattice degeneration, and vitreous liquefaction. And this happens because of disease progression. So rhegmatogenous component presents more late in age-wise. And most retinal breaks occur in the peripheral avascular area in the FEVR. And has good success rates from 80% to 94.6% based on PVR and macular status. This is staging that again has been covered by Rakshita. 1A is avascular peripheral retina. 1B is without exudation. 1B is with exudation. 2A is avascular peripheral retina with neovascularization without exudation. And 2B is with neovascularization with exudation. 3, 4, 5 is what the retinal detachment and what we will be dealing with, which is macula sparing RD, macula involving RD, or total RD. We can also find other findings such as white without pressure, vitreous bands, retinochoroidal atrophy, hemorrhages, neovascularization, dragging of the vessels. These are not specified in the classification but can be there. So the detachments can be presumed to be tractional when there is a vitreoretinal membrane of fibrotic mass with attachments either to the lens or the anterior vitreous, and the configuration of the retina is more concave. And there's absence of any extensive subretinal exudates or hemorrhage. Whereas it would be exudative when there is subretinal fluid and exudation and has a convex retinal configuration. The other ways to stage FEVR would be zone-wise, which is same as the ROP zones, or based on the progression where it can be rapidly progressing or slowly progressing. Moving on to the management of retinal detachment. So there are 2 ways to go about it, scleral buckling or vitrectomy. Scleral buckling is preferred in stage 3 or 4, where the aim is to support the area of the traction and the underlying vascular activity, and in cases where rhegmatogenous RD is because of simple retinal breaks. Whereas vitrectomy is the preferred form of surgery in cases of stage 5, which is the total retinal detachment, where removal of vitreous and all tractional forces is necessary, or if the rhegmatogenous component has multiple breaks, posterior breaks, or presence of significant PVR. Vitrectomy can be combined with lensectomy if the fibrovascular adhesion is with the posterior capsule, and it can also be combined with the buccal when there is a need to support the PVD edge or the trimmed fibrovascular proliferation. So scleral buckling in FEVR, I'll be discussing both the surgeries based on tractional and rhegmatogenous components separately. So in buccal, the tractional component, in tractional component, the buccal not only reduces the tractional force of the FEP but also reduces its activity. So there was a cell culture study that showed that stretching of the vascular endothelial cell body causes increased sensitivity to VEGF. So because of buccal, we try to reduce the stretching of these cells and down-regulate the sensitivity to VEGF and stabilization of new vessel formation. Also, when the FVP is in extreme periphery, and vitrectomy is not possible without sacrificing the lens. In such cases, buckle would be the preferred surgery. So this is the pre-op picture of a 12-month-old child which had these radial folds and a vascular rich fibrous growth. And this is the post-op picture where the radial folds had reduced and there was a whitish, less vascular prolif left. This is post-buckle. And same thing in the angiogram shows that there was fluorescein leakage at the site of that fibrous proliferation, and post-operatively the leakage had reduced. Moving on to rhegmatogenous components. So buckle for simple retinal breaks in mild FEVR rhegmatogenous relative detachment yields a very good visual and anatomical outcome with success rates ranging from 80 to 94% based on the PVR grade and the macula status. So I'll be discussing a case. This is a 4-year-old female presented to us with drop in vision in her left eye since 8 months and squinting of the left eye since 4 years. She had undergone examination under anesthesia where laser was done to the right eye, and she was referred here for the management of left eye. So this is the same case that Rakshita had discussed previously for the medical management. I'll be discussing the other eye. So the right eye fundus shows a hypoplastic disc, temporal avascular retina with some laser marks. And the left eye again shows a very small disc, inferior subtotal RD with subretinal gliosis and preretinal traction in about 2 quadrants. This is the angiogram of the right eye showing peripheral avascular retina, and this area has not been treated. And this is the left eye, which is showing again that peripheral avascular retina and some leakage here. So this patient underwent a 276 buckle with the 240 encirclage, 2 sutures in the inferotemporal quadrant and 1 in the superotemporal quadrant. And SRF drainage was performed in the inferotemporal quadrant. This is at post-op day 4, the retina was attached, and at glass appointment, she was reading 636 with minus 13 diopters. So role of vitrectomy, again classifying the tractional and a rhegmatogenous component. So in tractional component, when the fibrovascular proliferation is over 2 or more quadrants, buckling may not release this wide traction. So dissection, what vitrectomy does in these cases is dissection and delamination of the fibrovascular proliferation that contains these new vessels, and to remove the vitreous gel around the fibrovascular proliferation along with the proliferation, and to wash away the VEGF from the vitreous cavity. So again, this is the pre-op picture of an 8-month-old child which was showing the fibrovascular proliferation and some hemorrhages. Underwent vitrectomy, and this was post-operatively. The FEP had reduced vascularity and the retina was more or less settled. And the angiogram was also showing the same thing, that there was leakage before and there was no leakage post-operatively. For rhegmatogenous component, vitrectomy is indicated in cases of posterior retinal breaks, advanced PVR with retinal membranes, giant tears, extensive areas of degeneration, multiple peripheral retinal breaks, and in cases with cataracts and vitreous opacity where buckling will not be possible. Another option is to combine vitrectomy with scleral buckling. So the main challenge in FEVR is to the peripheral ischemic retina, which is posterior to the traction, and the key of the surgery here is to separate the hyaloid from the nerve, then the macula, and then the trimming of the posterior cortical vitreous. So the peripheral traction often remains and it can be truncated and can be stabilized over time, but this is where a well-placed buckle can be helpful. And in cases of vitrectomy combined with scleral buckling, the success rates vary from about 30 to 60%. So this is a case where vitrectomy was done for vitreous traction and macular drag, which is another indication for performing vitrectomy other than retinal detachment. She is a 26-year-old female with no significant birth history of myopia and squint in parents. Gave history of low vision in her right eye since childhood, and she's undergone some laser which we have no records of. And her right eye also underwent squint surgery 1 year back. So right eye was 660 with minus 15 diopters, showed a myopic disc with dragged vessels, absent foveal reflex, and peripheral avascular retina with a ridge-like structure and some lattices inferiorly. The left eye was 6'9" with minus 10 diopters. a thickened opaque hyaloid with some scarring temporal to the macula and some subretinal exudation inferiorly, along with peripheral avascular retina and some hazily seen laser scars. Her angiogram was showing the same thing, peripheral avascular retina in the right eye. So we thought that right eye was most likely amblyopic due to the anisometropic myopia. The left eye was again showing the opaque thick hyaloid with some subretinal exudation. This is the right eye OCT, which was showing a somewhat intact foveal contour. Left eye OCT was showing traction at temporal to the macula and a drag. She was observed for 3 months. She came back with visual acuity drop to 618 with vitreous haze and membranes and exudation on the retina, with a suspected fold at the macula with a query macular hole. The OCT was showing a pseudo hole in the vit membranes, and she also had posterior subcapsular cataract at this point. The ultrasound was showing vitreous echoes more in the left eye than the right eye, and these reflective membranes suggestive of IPVD with attachments at the mid periphery causing focal traction. There was also vitreous chysis, but the retina was attached elsewhere. So she underwent phaco IOL pars plana vitrectomy with laser. Anterior vitrectomy was done, and then the membranes were trimmed, truncation with the cutter as much as possible, and the attachments at the disc was relieved. And the vitreous was very adherent temporally, so that was left as it is. And base excision was done wherever possible, and then the laser was done to demarcate all these areas. On glass visit, she was 7.5 with minus 2.5 diopters, and the OCT pre-op and post-op showed relief of the traction at the macula. This is not this case's video, but a surgical video showing posterior hyaloids physical characteristics in a long-term case of FEVR. So basically, the vitreous condensation can cause thick epiretinal membranes and macular distortion while the hyaloid contracts. So this is where the new disease is active and has to be removed. And if the vitreous temporal to the avascular retina cannot be relieved, then that area can be supported with the buccal or an encerclage. Another case where most commonly what we prefer is to go with buccal in the first sitting and then perform vitrectomy in the second sitting if required. So this is a case of vitrectomy for a scleral buccal recurrence. 9-year-old male presented with diminution of vision in both his eyes, more in the right eye since 6 months. So right eye had total retinal detachment with a superotemporal break and subretinal gliosis inferiorly along with straightening of vessels. This was the angiogram. Left eye was showing a temporal avascular retina, some lattices and straightening of vessels. So this patient underwent right eye scleral buccal 279 with 240 encerclage and left eye laser to the peripheral retina. 2-quadrant buccal, 2 sutures in the superotemporal quadrant where the break was and 1 suture in the inferotemporal quadrant. On post-op day 4 only, he had inferior SRF. Then when he came back on glass appointment, we took up the patient for pars plana vitrectomy, EL and oil tamponade. So drainage retinotomies were made to release the subretinal gliosis nasally, and with PVD was induced up till the edge of the buccal. This is at glass appointment. He's 624 with plus 3 diopters. There is some nasal traction which is reduced from, he came back again actually 2 days back, and this nasal traction is reduced, but we've advised for EL re-SY. This is another video. It's a 35-year-old male, one-eyed patient, suspected FEVR. He underwent barrage laser followed by cataract surgery, and then came at glass appointment with a macular hole with RD. So we took him up for pars plana vitrectomy, ILM peeling, laser and oil tamponade. The vitreous was very adherent and sticky, and PVD induction was difficult and also led to multiple breaks. So we start at the disc. You separate the vitreous from the nerve and then go about posteriorly wherever it's possible. One second. The key of the surgery here is to separate as much hyaloid as possible, especially at the junction of the peripheral avascular and vascular retina. Eventually, forceps was used to trim the induced PVD as much as possible in the periphery and also remove the membranes. And then finally, ILM peeling was done, and fibrin glue was injected over the breaks and the macular hole. And then a 1300 centistokes silicone oil tamponade was injected. This patient came back at glass appointment with a vision of 636. OCT was showing ill-defined fovea with choroidal thinning. So, what is the role of anti-VEGF in FEVR? So, basically, anti-VEGF can be used in two sittings separately as standalone treatment in high vascular activity of fibrovascular proliferation, or as an adjunct to or before either laser or surgery. So, in high vascular activity, if there is presence of vascular dilation, neovascularization, and hemorrhages, retinal exudation. So, in these cases, conventional laser photocoagulation will not be possible. So, anti-VEGF can be injected, and once the exudation comes down and shows regression and reduction in the subretinal fluid, it will facilitate laser. And if at all, even then, if laser is not possible, then we can plan for surgery. So, this is a case where FFA was showing significant leakage and hemorrhages, and post-injection, 4 months post-injection, the hemorrhages and exudates had come down, but there was still tractional retinal detachment. So, the patient underwent buccal surgery and was stable afterwards. So, this is a case where anti-VEGF was used for exudation and SRF in FEVR. So,
leakage reduced, which is the image reduced leakage showing are not there here.
this one.
But what was pre-injection and post-injection? Lower image looks there were more leakage. So which is that one? Which one is pre-injection, which is post-injection?
So these are two different patients. This first patient is, this is 1 month post, and this is the second patient which is 4 months post where the traction did not reduce, so this patient underwent buccal. In this case also, actually this is a case that was operated by Dr. Chessy in 2002 and then at the age of 4 months, and was on regular follow-up with us since 2008. So she's undergone multiple surgeries in both the eyes, and left eye always had exudation and subretinal fluid. So basically, this was right eye, counting fingers 2 meters, stable OCT after multiple surgeries. This is the left eye. So this is in 2017, and then this is in 2019. It was showing increased exudation with subretinal fluid, and SRF drainage was not possible because there was belt buckle and conjunctival scarring. So this patient was planned for anti-VEGF with a trial of laser photocoagulation around the inferotemporal abnormal vessels once the exudation comes down. And we wanted to monitor closely for development of any regmatogenous component. In case the laser photocoagulation does not take up or the subretinal fluid increases, we would like to plan this patient for surgery. So this was in April 2019. And this is in September 2019. So this patient underwent 4 injections in July, August, October, and then lens aspiration with injection under steroid cover in November. And eventually the SRF did not settle and was finally taken up for revit, retinectomy, membrane peeling, and oil tamponade. And currently the patient is stable at 3/60. The last point here is when not to operate. So when there is a chronic retinal detachment with fellow eye with normal vision that can
Did
be
you see the OCT before? How the retina was?
here. Yeah, this one.
Yeah, you just see the retina.
Hmm.
There's hardly any organization of the retina. In fact, there's moth-eaten appearance completely. It's like the only retina which probably looks all right is probably inferior to that on the OCT scan along the vessels inferiorly. Otherwise, most of the retina is all degenerated. So, child has 3 by 60 is amazing.
No, this,
Yeah.
3 by 60, yeah.
No, not this at this stage. I'm talking about after
Later.
surgery. But you can see there's hardly any organized retina. The retina is completely, there's a moth-eaten appearance.
Even in this size, she's at counting fingers,
So
2
you
meters.
can see where at least there is some organization, but you can see inner retina as a one. But the child is not seeing well. That's why it's just poor averaging. It's poor averaging. That's why the child probably is having nystagmus and no fixation. So this is just poor averaging. Swept source doesn't give you that great images. It just nicely washes it up. So this tissue is abnormal, and all that is you're just able to see something. That's the quality of imaging. But that helps you at least to make a decision. Whereas the right eye and the left eye is, if you look at the left eye picture, yeah, you see this, it's all moth-eaten. There's nothing there. And same here. See, the outer retina is such a small thing. Most of the inner retina is some vague tissue. Doesn't look like normal retinal tissue. So the child is seeing somewhere from here, I think. Not all this is all kind of degenerate retina, but still the child is. So you have to be persistent. The final lesson is that you have to be persistent. If it is possible surgically, go ahead. Don't stop. So that's why the number of surgeries you can see in that.
Yeah.
Finally succeeded at 3 by 60. After all that.
Last follow-up.
Last follow-up, sir. Actually, now she's developed a membrane and BSK. So now
That's
she's being
hypotony.
hypotony and BSK. Now she's being following up with cornea clinic. Her last follow-up was last year.
This is Lavanya you're talking
Yes,
about.
sir.
Yeah.
And that membrane is actually nothing but a cyclotic membrane. Because of hypotony, it's an injury to the ciliary body ultimately.
Yeah.
How many surgeries we had to do
Yeah.
to get it to this level? It's amazing. 3 by 60 is truly a miracle.
No, but now she's gone down to hand movement, sir, because of the BSK.
Now, again, another message what Chetan has said now, that you have to continue because they are desperate situation. You keep on working and don't ignore other eye. Because other right eye was always poor, all concentration always on the left eye. Multiple surgeries were done, everything is tried, and initially left eye was good. And with all this thing, everybody was ignoring right eye. And today's scenario is she is managing everything with the right eye. The 360 which was there in the right eye is still maintaining over so many years, and that eye remains stable. This eye ultimately eventually deteriorated. So just don't ignore, because and this is not uncommon to happen in this type of ROP, FEVR, these are the things. Don't think like other eye is poor, nothing is going to happen. Ultimately, sometime eventually what happens is that poor eye, which is now her functional eye, okay, she is grown up now, very confident girl, managing everything on her own, but now the one which was everything happened in the left eye, ultimately that is lost, which was initially good eye. So that also keep that thing. That's one more lesson I wanted to take from this case.
Also teaches that the disease is extremely asymmetric. The right eye story is different from the left eye story. So both stories have to be taken care of. Each visit. Can't ignore it.
So when not to operate, so if there's a chronic retinal detachment with fellow eye with normal vision, it can be observed. In stage 3, if the macula is attached and vision is presumably good, especially if the RD is focal and far in the periphery, this can be treated with laser and observed. In stage 4, basically has retinal folds. So retinal folds that are vascularly active and broad with edema and exudation will have to go for surgical intervention. But thin folds with retina-retina adhesion without any vascular activity can be observed, as the risk for iatrogenic breaks is very high and vision often does not improve in these cases. These folds will also require lensectomy, which is again another challenge for visual rehabilitation. So this is a case with chronic RD with a fellow eye normal, 2 years old male with a normal birth history, positive family history in the father, was tested genetically, had LRP5 gene mutation, and he came with left eye squinting and diminution of vision since birth, and right eye maintaining good visual acuity. So this is the right eye of the patient, which was showing avascular retina with wedge, and this is the left eye, which showed a falciform fold, which was mostly dry, with anterior proliferation and a retrolental opacity. We took up the child for examination under anesthesia. The right eye was 6/6 and laser was done to the peripheral avascular retina except the nasal periphery. The left eye was decided to be best left alone, as first the falciform is extending up till the ciliary processes and there was no potential space between the falciform fold and the ciliary body. And the second was that it was reaching up to the retrolental space temporally, but it was sparing the visual axis. And the superior retina was attached, and the posterior pole had only shallow subretinal fluid. So we decided to observe this eye. This was post laser right eye, and an angiogram was done, which was showing still some leakage. So augmentation of laser barrage was done, and this is 4 months later when the right eye was stable and the left eye also, the traction was reducing. Coming to literature review, this is an in-house study showing the outcomes of surgery in eyes with FEVR associated retinal detachment. This was a retrospective study done from 2004 to 2017, where 44 eyes of 38 patients between the age group of 5 months to 51 years were taken. So this study showed that in retinal detachment, rhegmatogenous component was more, which was about 79.5%, that is 35 eyes, and tractional component was less, which was 20.5%. And based on the choice of surgery, scleral buckle was done for peripheral outer retinal breaks with clear media without any significant PVR. And pars plana vitrectomy was preferred for eyes with tractional retinal detachment, posterior breaks, and PVR more than grade 2. So there were 31.8% eyes that underwent buckle and 68.2% eyes that underwent vitrectomy. In 14 eyes, the vitrectomy was combined with lensectomy, and either oil or C3F8 tamponade was used. So this is the outcome analysis. In buckle, 78.6% patient eyes were attached after a single surgery, whereas 85.7% required resurgery. And in vitrectomy, 73.3% were attached and 83.8% required multiple surgeries. So more or less equal. And the main reason for failure was PVR.
Like how is the...
I know it doesn't add to 100%, ma'am. It was basically, the analysis was combined for both buccal and vitrectomy. So all the eyes that underwent resurgeries in both the cases were taken.
It is the final outcome percentage, or is this first surgery outcome percentage?
I think the other one shows the second surgery or the multiple surgery success.
Yes.
So there is a mixture. I'm
Sure. It was basically all the eyes that underwent resurgery and then finally showed attachment, where the first surgery was either buccal or vitrectomy based on that.
How would you analyze this?
What is your takeaway?
What is your take from this?
My take was that it basically, it was not dependent on what the first surgery was. Whether if it has to attach, then if it has to go for recurrence, then it will, whether it was a buccal or a vitrectomy.
I will take it the other way, that you should keep trying.
Yeah.
Even if there is a failure after, because the success is touching 85 in such patients, which is a very good outcome.
Yeah, there were patients, most of these patients were settled after the second surgery, but there were some that required more than 2 also.
So ultimately, you cannot do the other way around. You can do buccal and then you can do vitrectomy, or you can do with buccal.
Yeah.
But you can't do...
You can't do vitrectomy first and then, yeah.
So that is the basic consensus.
So vitrectomy is extremely difficult in these eyes. PVD induction, all those things so difficult. That's why always, if possible, you try buccal.
Buccal first.
And then, and that's why most of the time vitrectomy, what you are seeing is either second surgery, or because those eyes are invariably bad, that's why so naturally outcome also is not going to be. So that natural bias comes into play.
Also, if you look at the anatomy, ROP surgeries, the central vitreous stalk becomes opaque, pulls the retina towards the lens. Whereas in FEVR, you don't get a central opaque stalk. You get peripheral vitreous which changes because the central, it depends upon, of course, how much of the retina was vascularized. Most of the retina is usually vascularized because it doesn't depend on the age. It just depends on when these what you call gene mutation kicks in and causes a problem with the development of the vessels. So usually it's in the periphery, as usual. All the vessels generally grow from the disc and go up to the periphery symmetrically around the disc. And when there is a genetic mutation kicks in, then the peripheral avascular retina remains avascular and undergoes all the changes. So by that time, usually the central vessels that are usually there in the primary vitreous, that is your primary, the Cloquet's canal and everything, is all dried up and there's no real tissue there to pull. So you don't get that central tissue pulling towards a disc in an FEVR unless it is kicked in very early in utero. Everything you see in the periphery. And more often the temporal periphery, because that's the last part of the retina to get vascularized. And then you start seeing everything like a macular drag, peripheral folds, falciform folds. You don't see falciform folds and nasal quadrant in FEVR. You either see a total RD, closed funnel, or you see, depending on how young the patient developed the tractional component. So that is something when you look at the fundus, look at the timeline of the disease, you can get to know that this is an FEVR, and most of the pathology is usually in the periphery, temporal periphery, and hence all these things. So imagine if the temporal periphery is pulled, the macula is generally gone, and is the most difficult thing to achieve. So that's why that retina adhesions that you talk about, that is the falciform fold you're talking about. Yeah. The retina has stuck on itself, and then whatever you do, you're not going to get macular vision. You'll get some other vision, some type of found vision the child will get, peripheral vision, but not that. So that is the problem with the vitreous in the FEVR cases. So you try to do PVD induction, no? You're not going to get a beautiful PVD coming off the disc and going up to the periphery. You have to restain with maybe IVTA or something and all. Keep pulling. And if you have had a recurrence, it means that one thin sheet of vitreous is probably still there on the retinal surface, which has progressed and acted like a scaffold for the redetachment. So many times we feel happy that we have done a good job, and many years later we see that there is again a new vessel, and that new vessel has induced some more fibrous metaplasia of the posterior hyaloid, which is still stuck on and continue to cause attraction. So you can keep repeating your FFA also, okay? That's another indication to keep repeating FFA to see where the new vessels are and what is the, where is the new vessel, because that's where the traction has started. That's where the disease has again started, causing the exudation and the fibrous metaplasia of the leftover posterior hyaloid, which is the cause for the retina to keep detaching. So it's a disease basically of tractional. But when you do vitrectomy, you end up making it regmatogenous most often than not. And that's why vitrectomy is so dangerous in these cases.
Yeah, I think interpreting this slide, actually it is single surgery success rate is around 78%, and at the final follow-up it was 86 for buccal, and similarly 72 single surgery success rate for PPV, and at the end of after multiple surgeries the rate increased to. So that's how you read this slide. Right. Okay. Yeah. Now as far as FEVR is concerned, I think as Chetan said, it's more tractional. So the reason why you would do a buccal is because it's edematous retina, there's a lot of exudation. So you're prone to create problems if you try to induce PVD, which is why we do a buccal to start with. And then even if you go in repeatedly, it is better to be conservative rather than very aggressive. Because once they develop a hole in the retina, then it becomes extremely messy. As long as they are tractional, if vitreous membranes reoccur, you can always remove them because it's a hyaloidopathy. So there is pathological vitreous, which you have the membranes coming back again and again. And sometimes you can also develop stretch holes in the macula. So that's why you want the buccal on the side, so that that incidence of those stretch holes reduces.
Talking of outcome, the visual acuity improved in 28 eyes, stabilized in 9 eyes, and deteriorated because of recurrence in 7 eyes. And presence of folds would necessitate relaxing retinectomy, and also that tractional retinal detachment cases had poorer outcomes as compared to regmatogenous. And the factors for poor anatomical outcome were poor pre-op BCVA, female sex, presence of falciform folds and young age, and whereas functional component was again female sex, total RD, which is basically dependent on the macula status, whether macula was off or on, more than 2 quadrants of avascularity and traction, and falciform folds. This is a review article by Dr. Michael Tracy, which again showed results of surgical management. In this case also, it's a very similar study where 40 eyes were treated either with laser, buccal or vitrectomy depending on the stage. So 32 eyes underwent surgery. And in the last follow-up, macula was attached in 62% eyes. So this is stage wise. So stage 1 was observed. Stage 2 was treated with laser, in which half of the 6 eyes improved and stabilized. Only 1 eye progressed and they had to do surgery. In partial retinal detachment with a predominant tractional component, if the lens was involved, they did a lensectomy with vitrectomy, and if not, then lens sparing vitrectomy. And there was 1 eye which underwent buccal. And in macula involving, they preferred vitrectomy over buccal. Same thing with a predominant exudative component. They preferred doing buccal in exudative RD, whereas for tractional RD, they had preferred doing vitrectomy. And in partial RD, they initially tried laser photocoagulation for 4 eyes, in which 2 eyes showed improvement and they did not go for surgery, whereas 2 eyes needed surgery. And in total retinal detachment, vitrectomy was preferred in open funnel RD. In closed funnel RD, wherever there was no visual potential, they did not intervene. So this is the outcome. In stages 3 and 4A, they achieved a good visual acuity with macular reattachment. And as the stage progressed, obviously the macular reattachment and the vision outcomes both were poor. So what they concluded was that stage 1 requires no therapy and can be observed unless it's a fellow eye of an advanced FEVR. Then in those cases, we prefer to do laser. Stage 2 has excellent results with laser alone. Stage 3, buccal or vitrectomy depending on the extent of the detachment and the location and the degree of the vitreoretinal traction. And as the stage progresses, there is less promising results. And early intervention, they've also found that early intervention was beneficial and that the affected patients require lifelong regular follow-up and screening of the family members as well. These are my acknowledgements.